Welcome to the deep dive. Today, we're plunging into a truly fascinating and sometimes, frankly, a little frightening aspect of our own bodies. The immune system. This incredible network is constantly on guard, an intricate defense system designed to protect us from, well, an endless array of threats, from bacteria and viruses to rogue cells within our own bodies. It's our front line, our protector. But here's the paradox we're going to unpack today. Sometimes, this powerful defense system, designed to keep us safe, misfires or overreacts. It can flip the script and actually cause us harm, turning our ultimate protection into a double-edged sword. This is the intriguing and often challenging realm of hypersensitivity reactions, which many of us commonly know as allergies.
It's a remarkable aspect of human biology, isn't it? We often idealize our immune system as this perfect, infallible guardian, always acting for our benefit. But the reality, as we'll see today, is far more nuanced, even a bit counterintuitive. Hypersensitivity reactions aren't typically a sign of a broken or deficient immune system. Quite the opposite, in fact. They're described as an undesirable immune response by a normal immune system.
A normal system, so it's not failing.
Exactly. Think of it not as a failure, but as an extreme overreaction. It's an exaggerated response to an antigenic challenge, essentially, an altered reactivity that occurs upon re-exposure to an antigen to which there's been prior contact. The system isn't malfunctioning, it's just reacting too intensely, too aggressively perhaps, to something it shouldn't be harming.
That's such an important distinction because it reframes our understanding. Your body isn't failing you, it's simply reacting in an unexpected and unfortunately harmful way. And while we often use the word allergy casually in everyday conversation, for sniffles and things, it's actually a common term for specific types of hypersensitivity reactions. These aren't just minor irritations that make you sneeze. They can lead to significant tissue damage and, in severe cases, be life-threatening, even fatal.
Which brings us to a fundamental question. How does this dramatic overreaction actually come about? The core principle behind all hypersensitivity reactions, regardless of their specific type, is that they invariably occur in two distinct sequential stages. It's never a first-time event where the immune system immediately attacks.
Ah, okay. So it's like a two-act play, or perhaps like a spring being loaded before it launches. The first stage is what we call the primary exposure, the sensitization phase, right?
Precisely.
This is the immune system's initial encounter with a specific antigen. During this first contact, your immune system essentially takes notes. It learns about this new substance, remembers it, and becomes primed for future encounters. It's building a memory, but not necessarily an immediate weapon yet.
Exactly right. It's like the system has received its initial training, its briefing on the potential threat. Then comes the second stage, the secondary exposure.
The shocking dose.
Often referred to as the shocking dose, yes. This is when you re-encounter that same antigen that your immune system has already been sensitized to, and that's the critical moment. This subsequent re-exposure is what then elicits the injurious consequences, causing the actual reaction to manifest in your body. It's when that loaded spring finally launches.
Okay. To help us navigate this incredibly complex landscape, we'll be relying on a widely accepted and incredibly useful framework known as the Gell and Coombs classification. This was established way back in 1963, I believe.
That's correct, 1963, and it's still the standard.
And this system is crucial because it doesn't just list reactions. It categorizes them logically based on their onset time, how quickly symptoms appear, and perhaps even more importantly, the specific immune mechanisms involved. It's like the immune system's own periodic table for these overreactions, sort of mapping them out.
It really is. And this classification truly acts as our roadmap for this deep dive. It cleanly divides hypersensitivity into two broad categories. We have immediate hypersensitivity, which encompasses type 1, type 2, and type 3 reactions. These are primarily antibody-mediated and manifest quite rapidly, typically within minutes to a few hours of re-exposure.
Minutes, hours, okay, that's fast.
Very fast, relatively speaking. Then, distinct from these, we have delayed hypersensitivity, which is type 4. This one is fundamentally different because it's cell-mediated.
Cell-mediated, not antibody. Got it.
Right. Meaning it involves specific immune cells rather than antibodies, and as its name suggests, it takes a much longer time to manifest, usually days. This structure will guide us through the fascinating and sometimes alarming quirks of our immune system.
Let's dive right into the immediate ones then, starting with type I hypersensitivity. This is truly the poster child for what most people envision when they hear the word allergy. We're talking about the classic anaphylactic IgE-mediated immediate reaction. And when we say immediate, we mean it. Symptoms typically erupt within minutes of re-exposure to whatever allergen triggers it, a sudden and sometimes dramatic cascade.
That's absolutely right. The core characteristic of type I is its primary mediation by a specific type of antibody, IgE. And the key cellular players in this drama are mast cells and basophils. The spectrum of symptoms is incredibly wide, as you mentioned, ranging from something as mild as a seasonal irritation, perhaps itchy eyes or runny nose, to, in severe cases, a life-threatening, sudden systemic collapse.
Oh,
And this type of reaction is also strongly associated with atopy.
atopy, what's that exactly?
Oh, it's basically a genetic predisposition. Individuals who are atopic have an inherited tendency to produce unusually high levels of IgE antibodies in response to common environmental antigens, things that don't bother most people. It's not just a random occurrence, there's often a familial link.
Okay, so how does this cellular cascade of overreaction actually work? Let's break down the mechanism, starting with that crucial first exposure, the sensitization phase. Imagine an allergen, say, pollen, certain food proteins like peanuts, or a drug like penicillin enters your body for the very first time. This could happen through inhalation, like breathing in pollen.
Or ingestion from eating a particular food.
Or inoculation, like an insect sting, or even just direct skin contact. So your immune system encounters this seemingly harmless substance. What happens then?
During this initial encounter, a specialized subset of T lymphocytes known as T helper 2, Th2 cells, become activated. These Th2 cells are like the orchestrators here. They release specific cytokines, chemical messengers, that then stimulate another type of immune cell, the B cells, to undergo a process called class switching. Yeah, instead of producing other types of antibodies, these B cells are now directed to produce a large quantity of IgE antibodies specifically tailored to that allergen. And here's where it gets really interesting. These newly produced IgE molecules don't just float around aimlessly. They have a unique affinity for high-affinity Fc receptors found on the surface of both mast cells and basophils.
Fc receptors, those are like docking stations.
Exactly. The IgE molecules bind very tightly to these receptors, essentially arming or sensitizing these cells. It's like installing highly specific allergen detection alarms on them, preparing them for any future encounters.
So these mast cells and basophils become walking prime time bombs, covered in IgE antibodies, each one waiting for its specific allergen key to unlock it.
That's a good analogy.
Then comes the second act, the re-exposure, that shocking dose. When the same allergen shows up again, perhaps you eat a peanut or breathe in pollen a second time, it doesn't just bind to one IgE molecule. What happens?
Instead, the allergen acts like a bridge, simultaneously connecting and cross-linking multiple IgE molecules that are already bound to the surface of those sensitized mast cells and basophils.
Cross-linking, like connecting the dots.
Precisely. And boom! This cross-linking is the critical trigger for a rapid and explosive release of powerful chemical mediators. This process is aptly named degranulation.
Degranulation, so
Yeah.
it's explosive.
Yes, degranulation. Picture these mast cells and basophils as tiny storage depots, packed with preformed, potent chemical mediators inside their granules. The cross-linking of IgE acts as the signal to immediately release these mediators into the surrounding tissues. These release mediators are the true orchestrators of all the diverse and often dramatic symptoms we associate with an allergic reaction, from a runny nose to systemic shock.
And there are a lot of them, right? Each playing a distinct disruptive role. Let's talk about the primary mediators first. These are the ones preformed and stored in the granules, causing that almost instantaneous blast of symptoms. The principal player, the one that kicks off most of the classic allergic reactions you recognize, is histamine, isn't it?
Absolutely. Histamine is the main culprit for many of those immediate effects. This powerful substance acts swiftly. It causes vasodilation.
Widening blood vessels.
Right, which leads to the characteristic flushing and warmth you might see. It also dramatically increases capillary permeability, allowing fluid to leak out of blood vessels into surrounding tissues.
Which is why you get swelling in hives, or urticaria.
Exactly. And histamine also causes smooth muscle contraction, which is particularly dangerous in the respiratory tract. It leads to bronchoconstriction, the tightening of airways that makes breathing incredibly difficult, like in asthma or anaphylaxis.
And it stimulates sensory nerves, too.
Yeah. Yes, resulting in the intense itching, burning, and pain associated with allergic reactions. So when you think hay fever, widespread hives, urticaria, or sudden deep tissue swelling, angioedema, you're often thinking histamine.
Okay, but it's not just histamine, right? The immediate blast also includes proteases and hydrolases.
Correct. These are enzymes that, once released, get to work breaking down components of the blood vessel basement membranes. This further contributes to the increased vascular permeability, allowing even more fluid to leak out and inflammation to spread. It's like they're actively dismantling the integrity of your blood vessels.
Making things leakier, basically.
Pretty much. Then we have the chemotactic factors, like eosinophil chemotactic factor, ECFA, and neutrophil chemotactic factor, NCF.
Chemotactic, meaning they attract other cells.
Yes, exactly. As their name suggests, these act as chemical beacons, attracting specific types of white blood cells, eosinophils and neutrophils, respectively to the site of the allergic reaction. While the immediate symptoms are driven by histamine, the arrival of these cells helps to prolong and amplify the inflammatory response, contributing to the later phases.
So they keep the party going, unfortunately.
In a way, yes.
And a couple of other important ones to briefly mention from the primary mediators. Heparin. Does that play a big role in humans?
Heparin is a natural anticoagulant. It contributes to anaphylaxis in some animal species, but its direct role in human anaphylaxis isn't as prominently understood as, say, histamine's role.
Okay, and serotonin.
Serotonin, or 5-hydroxytryptamine, is another potent vasoactive amine. It causes vasoconstriction, increased capillary permeability, and smooth muscle contraction. While very important in rodent models of allergy, its precise and consistent role in human allergic reactions is still less certain compared to histamine.
Got it. So histamine is really the star of the immediate show.
For the immediate phase, largely yes. But then, in addition to those immediate primary mediators, there's a whole second wave of substances. The secondary mediators.
Secondary, meaning they come later.
Exactly. These aren't preformed and stored. Instead, they are newly synthesized by the mast cells and basophils after the initial degranulation event. This synthesis takes time, which is why they are responsible for the more sustained and prolonged attack, particularly in the later phases of the reaction. A key group here are the slow-reacting substances of anaphylaxis, or SRSA, which are primarily leukotrienes like LTC4, LTD4, and LTE4.
It's truly fascinating because for years, the focus in allergy treatment was almost entirely on antihistamines, wasn't it?
Mm-hmm.
But the discovery of leukotrienes revealed why blocking just one mediator wasn't enough to control severe asthma. These leukotrienes are incredibly potent mediators, especially when it comes to persistent bronchoconstriction and asthma.
Mm-hmm.
Often much more potent than histamine in tightening airways, I read.
That's correct. They also contribute to increased vascular permeability and smooth muscle contraction, playing a major role in the late phase of the reaction, which can be particularly insidious for asthmatics.
It's like realizing you've only been fighting half the battle if you just focus on histamine.
Absolutely. Then you have prostaglandins and thromboxanes. Prostaglandins, like leukotrienes, also cause further bronchoconstriction, affect mucus secretion, and contribute to capillary permeability and dilation. They can even lower the pain threshold, making symptoms feel more severe.
Ouch.
And thromboxanes, on the other hand, are powerful stimulators of platelet aggregation.
Making platelets stick together.
Yes, which can lead to microthromby, tiny clots, and local ischemia, further exacerbating tissue damage and severe reactions. It's like a whole orchestra of chemicals playing different disruptive notes, leading to a complex symphony of symptoms.
And finally, a crucial group that orchestrates much of the sustained response. Cytokines, right? Like IL-4, IL-5, IL-6, and TNF-A.
Yes, cytokines are key players in the longer-term response. They essentially re-engineer the local microenvironment, acting as powerful signals to recruit even more inflammatory cells like neutrophils and eosinophils to the site of reaction. In systemic reactions, this widespread cytokine release can significantly contribute to anaphylactic shock, driving systemic inflammation and circulatory collapse.
And specific ones do specific jobs, like IL-4 boosts IgE.
Exactly. IL-4 plays a crucial role in boosting more IgE production, creating a vicious cycle, and IL-5 is absolutely key for recruiting those eosinophils to the site of inflammation, contributing to chronic allergic conditions like asthma.
Wow. So thinking about this complex array of mediators, we can clearly see why type I reactions typically unfold in two distinct phases.
Right.
First, there's the immediate phase.
Right, which occurs within minutes of re-exposure. This is driven by the rapid vascular and smooth muscle reactions, primarily due to the explosive release of those preformed mediators we just discussed. It's the immediate, dramatic, visible reaction you see.
The hives, the sneezing, the wheezing.
Often, yes. And then there's the late phase.
This one is often more insidious, you said, developing typically 4 to 6 hours after the immediate phase and capable of persisting for 1 to 2 days.
That's right. This phase is characterized by the synthesis and sustained release of those secondary mediators. We just detailed the leukotrienes, prostaglandins, cytokines, along with the recruitment of additional inflammatory cells like eosinophils and neutrophils. This influx of new cells and ongoing chemical synthesis significantly amplifies and prolongs the symptoms, making it a persistent challenge for the affected individual. For example, in asthma, the late phase contributes to chronic airway inflammation and hyperresponsiveness long after the initial trigger is gone.
Okay, so what does this all mean for us clinically? What do these reactions actually look like in a human body? The most traumatic and life-threatening manifestation is systemic anaphylaxis, right? Anaphylactic shock.
Absolutely. This is an acute, widespread, multi-organ reaction that represents a true medical emergency.
It truly is. The symptoms are terrifying and progress rapidly. Intense itching, generalized flushing and warmth, widespread hives, urticaria that spread across the body.
And deep tissue swelling, angioedema, which can affect lips, eyelids, or even deeper tissues like the throat.
Critically, there's severe bronchospasm, leading to terrifying wheezing and profound difficulty breathing, alongside laryngeal edema, throat swelling. That can block the airway entirely, can't it?
It can, very quickly. Simultaneously, there's often a dangerous and rapid drop in blood pressure, hypotension, due to widespread vasodilation and fluid leakage, and even cardiac arrhythmias can occur. If left untreated, it can rapidly be fatal, often from asphyxiation due to airway obstruction or from irreversible circulatory shock.
Just terrifying. What are the common triggers for something that severe?
Common triggers for systemic anaphylaxis include certain insect stings, particularly from bees or wasp-specific drugs. Penicillin is a classic and well-known example that has caused countless anaphylactic reactions due to widespread use and sensitization in certain foods.
Foods like seafood, peanuts, tree nuts.
Exactly. Those are notorious culprits. The swift recognition and treatment are paramount.
Which is why epinephrine, or adrenaline, is the absolute first-line treatment, right?
Yes, the drug of choice for systemic anaphylaxis. Administered rapidly, it works by constricting blood vessels and raising blood pressure, opening airways, and helping to reverse the life-threatening effects almost immediately. Antihistamines and corticosteroids are also used to help manage the symptoms, but they are secondary to epinephrine.
Okay. But beyond these life-threatening systemic reactions, there's also localized anaphylaxis, often referred to more commonly as atopy.
That's right. Localized anaphylaxis typically involves recurrent, non-fatal reactions that are confined to specific tissues or organs. These often have a clear familial predisposition, meaning they run in families, and affected individuals usually exhibit elevated levels of IgE antibodies in their blood.
And examples are things we see all the time.
Absolutely. Examples are widespread. Allergic rhinitis, which most people know as hay fever, characterized by sneezing, runny nose, and itchy eyes, often triggered by pollen from trees, grasses, or weeds. Then there's asthma, a chronic respiratory condition characterized by recurrent episodes of bronchoconstriction, mucus production, and airway inflammation, often triggered by allergens like dust mites, pet dander, or pollen.
And don't forget urticaria, those itchy red welts or hives that can appear on the skin, and atopic dermatitis, also known as eczema, which is a chronic inflammatory skin condition characterized by dry, itchy, inflamed patches of skin.
Exactly. The specific symptoms and individual experiences really depend on where the allergen enters your body and which target organs are involved, whether it's the eyes, the respiratory tract, the intestines, leading to food allergies with gastrointestinal symptoms, or the skin. It's the immune system's localized overreaction.
So for prevention, especially with allergies that cause recurrent localized reactions, you mentioned desensitization, allergy shots.
Yes, desensitization, more commonly known as allergy shots or immunotherapy. This is a brilliant long-term strategy where small, gradually increasing amounts of the specific allergen are administered to the individual over an extended period. The goal here isn't to suppress the immune system, but to retrain it.
Retrain it. How does that work? It's like a strategic re-education of the immune system.
Kind of. The repeated low-dose exposure aims to induce the production of different types of antibodies, specifically IgA and IgG blocking antibodies.
Blocking antibodies.
Yes. These specific antibodies can actually bind to the allergen before it has a chance to cross-link IgE on the mast cells. Essentially, they act as a shield, intercepting the allergen. This prevents the IgE from binding to the mast cells and thus stopping the degranulation cascade before it can even begin. It's a remarkable way to dampen that exaggerated type I response over time.
That's clever, shifting the response away from IgE.
Precisely. It's a sophisticated strategy. And connecting this to the bigger picture, we also have a few related scientific phenomena that helped illuminate our understanding of type I reactions historically.
Like what?
Well, there's the anaphylactoid reaction. Clinically, it looks almost identical to anaphylaxis, similar dramatic symptoms like hives, swelling, blood pressure drops. However, crucially, it is not IgE mediated. Instead, the inciting agents, maybe certain drugs or contrast media, directly stimulate mast cells and basophils to degranulate, bypassing the IgE antibody pathway entirely.
So same result, different trigger mechanism,
Yes.
like a direct pressure switch instead of an Ig sensor.
Exactly. Then there's the Prasin's-Küssner, PK, reaction. This is a historical test, really important back in the day, though rarely performed now due to safety concerns.
What did it involve?
It was an in vivo test done in a living person. Serum containing IgE antibodies from an allergic person was injected into the skin of a non-allergic recipient. If the allergen was then injected into that same spot 24 hours later, it would cause a wheal and flare reaction, a red, itchy bump. It demonstrated IgE's unique ability to sensitize human skin, even in a different individual. It was critical proof that these specific reagenic antibodies, what IgE was then called, were responsible for transferring sensitivity.
So it proved IgE was the transferable factor.
Yes. And finally, the Schultz-Dale phenomenon. This was an in vitro test done in glassware. Smooth muscle tissue, typically from the gut of a sensitized animal, is isolated and placed in a bath. When the specific antigen is added to the bath, the smooth muscle contracts visibly. This provided an early, direct, and controllable way to observe the effect of antigen-IgE interactions on smooth muscle, further cementing our understanding of how these mediators cause symptoms like bronchoconstriction.
So these historical tests really help piece together the puzzle of type I.
Absolutely. They were crucial in understanding the precise cellular and molecular mechanisms.
Okay, let's just shift gears now to type 2 hypersensitivity. You called this one the cytotoxic attack. How is it different?
Well, unlike type OR, this isn't about rapid, widespread degranulation and fluid leakage. Instead, type 2 reactions kick in within hours and are primarily mediated by IgG and sometimes IgM antibodies.
IgN and IgM, not IgE.
Correct. And the core characteristic here is direct damage or outright destruction of target host cells, often our own cells, because these antibodies are mistakenly binding to antigens on their surface.
Cytotoxic meaning cell killing.
Exactly. What's truly striking here is how precise and devastating this mechanism can be. Once these antibodies, IgG or IgM, bind to specific antigens located directly on the surface of host cells, they can trigger cell destruction through two main pathways.
Okay, what are they?
First, through complement activation. The bound antibodies act as flags, activating the complement system, a cascade of proteins in the blood we mentioned briefly before. This activation culminates in the formation of something called a membrane attack complex, or MA.
The MA attack.
You could call it that. Imagine the MSC as a microscopic, self-assembling drill bit that punctures a target cell's outer wall. Once that hole is made, the cell can no longer maintain its internal balance, water rushes in, causing it to swell and ultimately burst, a process called cell lysis, or destruction.
Wow.
It's an incredibly efficient demolition crew, but in this context, tragically directed at our own vital cells, leading to their demise.
That sounds incredibly direct and effective, but yeah, tragically against our own cells. What's the second pathway?
The second way these antibodies trigger destruction is through antibody-dependent cell-mediated cytotoxicity, or ADCC.
ADCC, okay.
Here, other immune cells like natural killer, NK cells, macrophages, and neutrophils, which have specific receptors called FCR, recognize and bind to the tail, or FC portion of the antibodies that are coating the target cell.
So they grab onto the antibodies stuck on the cell.
Right. Once they bind, these FCR-bearing cells then directly lease or destroy the antibody-coated target cell, essentially executing it on the spot. It's another highly efficient killer mechanism, but misdirected in hypersensitivity.
So 2 ways antibodies can mark our own cells for destruction. What are some examples of this?
The examples of type 2 hypersensitivity are truly high-stakes cellular destruction, often with immediate and severe consequences. Consider blood transfusion reactions, specifically hemolytic transfusion reactions, HTR.
When someone gets the wrong blood type.
Exactly. These occur when a patient receives blood with ABO blood group antigens that are incompatible with their pre-existing naturally occurring antibodies. For instance, if a person with type A blood who has anti-B antibodies receives type B blood, their antibodies will immediately recognize and attack the transfused red blood cells. This activates complement and causes widespread destruction of those red blood cells. It can be life-threatening, leading to fever, chills, back pain, and kidney failure.
Scary stuff.
Mm-hmm.
And similar to that, but in a different context, is hemolytic disease of the newborn, erythroblastosis fetalis HDN.
Yes, HDN is another classic example. This is an alloimmune condition, meaning the immune response is directed against antigens from another individual, in this case, the fetus. It typically happens when an Rh-negative mother is exposed to and sensitized by Rh-positive fetal red blood cells during a previous pregnancy or miscarriage. The mother develops IgG anti-Rh antibodies.
IG can cross the placenta, right?
Precisely. In subsequent Rh-positive pregnancies, these maternal IgG antibodies are small enough to cross the placenta, enter the fetal circulation, and then attack and destroy the fetal red blood cells. This leads to severe anemia, jaundice, and potentially heart failure and brain damage in the baby. Thankfully, as you mentioned, rhogam injections can prevent sensitization in the mother, making this largely preventable now.
That's good news. What about drugs causing this type of reaction?
Absolutely. Another significant and often overlooked example is drug-induced cytopenias. Certain drugs, even common ones, can act as
Haptens. Those tiny flags again.
Exactly. Think of a hapten as a tiny, invisible chemical flag. By itself, it's too small to get the immune system's attention. But when it physically attaches itself to one of our own body's proteins, say, a protein on the surface of a red blood cell, white blood cell, or platelet, it suddenly becomes a complete antigen. This newly formed complex then induces the body to produce antibodies against these modified cells.
It's like a tiny, harmless pebble becoming a weapon when it's tied to a much larger rock.
Yeah.
So what happens then?
The result can be conditions like hemolytic anemia, where red blood cells are destroyed, a granulocytosis, a dangerous drop in white blood cells, making one susceptible to severe infection, or thrombocytopenia, low platelets leading to bleeding issues.
And this can happen with common drugs.
It can. This is why certain antibiotics like penicillin or anti-inflammatory drugs or others can sometimes have such profound and unexpected side effects for a subset of individuals who develop these antibodies.
And a really severe, almost heartbreaking example you said is rheumatic fever.
Yes. This is a non-suppurative complication that can arise after an infection with group A streptocarci, usually strep throat. The antibodies produced by the body to fight off the strep bacteria mistakenly cross-react with similar antigens found on our own cardiac tissues.
Molecular mimicry.
Exactly, molecular mimicry. They also cross-react with antigens in joints, skin, and even the brain. This binding then activates complement, causing widespread inflammation and damage, particularly to the heart valves. This can lead to permanent scarring and lifelong cardiac issues. It's the body's defense turning on itself in a devastating way, triggered by an infection.
Wow. Okay, this leads us to what is often categorized as type V hypersensitivity. You said this is a modification of type 2.
That's right. It's a truly fascinating twist. Here's the crucial distinction. Instead of leading to cell destruction, the antibodies in type B reactions actually have a stimulating effect on the target cells.
Stimulating, not killing.
Correct. It's like the immune system has accidentally put its foot on the accelerator pedal of a normal cell, causing it to go into overdrive rather than putting on the brakes or destroying the vehicle entirely.
That's wild. How does that work?
The mechanism is that these antibodies bind to cell surface receptors, but instead of marking the cell for destruction or blocking its function, they mimic a natural ligand or signal. This mimicry leads to uncontrolled proliferation and enhanced activity of the cell rather than its demise.
So uncontrolled cellular function like a misguided cheerleading squad, constantly shouting, go, 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 to a system that needs to be regulated. What's the classic example?
The classic example here is Graves' disease. In this autoimmune condition, autoantibodies specifically, long-acting thyroid-stimulating antibodies, often referred to as LAATs, bind directly to the thyroid-stimulating hormone, TSH receptors, found on the surface of thyroid cells.
And TSH normally tells the thyroid what to do.
Right. Normally, TSH from the pituitary gland binds to these receptors, stimulating the thyroid to produce just the right amount of thyroid hormones. But in Graves' disease, the LATS antibodies bind to these receptors and stimulate the thyroid gland constantly. This leads to the production of excessive, uncontrolled amounts of thyroid hormones, T3 and T4, causing hyperthyroidism.
Which leads to symptoms like weight loss, rapid heartbeat, anxiety.
Exactly. Increased metabolism, unintended weight loss, rapid and irregular heartbeat, palpitations, tremors, heat intolerance, anxiety, and sometimes even bulging eyes, exophthalmos. It's all driven by that antibody stimulation.
The sources also mention myasthenia gravis here under type V with a simulating effect. Now, I thought myasthenia gravis involved antibodies blocking receptors.
That's a great point, and often how it's primarily described antibodies blocking or destroying acetylcholine receptors. However, the source material we're referencing categorizes it under type V, possibly emphasizing the broader concept that antibodies in this category alter target cell function rather than just destroying them.
So the emphasis here is on the functional alteration by the antibody, whether blocking or stimulating.
It seems that way in this classification context. In myasthenia gravis, autoantibodies attack acetylcholine receptors at the neuromuscular junction, which are critical for muscle contraction. This interference, whether blocking or destruction, ultimately leads to debilitating muscle weakness and fatigue, affecting everything from eye movements to swallowing and breathing. It's fascinating how antibodies can have such diverse functional effects on cells.
Okay, that makes sense within that framework. Now let's transition to type 3 hypersensitivity. You called this the immune complex problem. How does this one work?
This type also has an onset within hours, similar to type 2 in timing. But the core characteristic here is that it's mediated not by antibodies directly attacking cells, but by the formation and deposition of antigen-antibody immune complexes.
Immune complexes, clumps of antigens stuck to antibodies.
Exactly. And the problem arises when these complexes, essentially clumps of antigens, bound antibodies deposit in tissues, triggering widespread inflammation and damage.
Why do they form? And why don't they just get cleared away?
Well, connecting this to the bigger picture, it's about the immune system attempting to clear foreign invaders, but doing it in an overwhelming or misplaced way. The formation of complexes typically occurs when there's an excess of antigen relative to the antibodies. This might happen with a persistent infection where the body is constantly exposed to the pathogen, or from repeated exposure to a foreign protein like a drug. When there's this imbalance, small, soluble antigen-antibody complexes are formed in the blood.
And this is where things go rogue, because unlike larger complexes, which are efficiently cleared by the body's mononuclear phagocyte system, the cleanup crew.
Right, the macrophages and other phagocytes.
These smaller, soluble ones are not.
They're not cleared efficiently. Instead, they circulate and find places to inappropriately deposit in various tissues throughout the body. They particularly seem to like the inner lining of blood vessel walls, causing vasculitis.
Inflammation of blood vessels.
Yes, and the delicate filtering units of the kidney glomeruli, leading to glomerulonephritis.
Kidney inflammation.
Right. And the joints, which can result in severe arthritis. It's like sludge building up in the body's filters and pipes.
That sounds bad. What happens once they deposit?
Once deposited, these immune complexes initiate a powerful inflammatory cascade. They activate the complement system, our familiar cast of proteins, which then generate signals that attract and activate a swarm of inflammatory cells, primarily neutrophils, to the site.
Neutrophils rush in.
Exactly. And these neutrophils, in their well-intentioned attempt to clear these stuck complexes, release powerful proteolytic enzymes, kinins, and highly reactive oxygen and nitrogen intermediates. This unintended and localized outpouring of destructive chemicals causes significant local tissue damage and widespread inflammation, almost like friendly fire during the cleanup attempt.
Collateral damage.
Significant collateral damage. Furthermore, platelet aggregation, often triggered by these intravascular complexes, can lead to the formation of microthrombi, tiny blood clots, and local ischemia, meaning reduced blood supply, which further contributes to tissue damage.
So it's like a messy cleanup job, where the cleanup crew accidentally causes massive damage to the house. Let's look at some specific examples. We have the Arthus reaction. What's that?
The Arthus reaction is a classic localized inflammatory reaction. It's caused by immune complex deposition at a specific site, most commonly the skin, often seen after repeated subcutaneous injections of an antigen into someone who already has high levels of IgG antibodies to that antigen. This can lead to localized edema, swelling, hemorrhage, bleeding, and even necrosis, tissue death, in severe cases at the injection site.
Can this happen elsewhere, not just the skin?
Yes. You can see this pattern in conditions like hypersensitivity pneumonitis, a group of lung diseases often related to occupation. A well-known example is farmer's lung, which results from inhaling spores from moldy hay. Repeated exposure to the fungal antigens leads to immune complex formation and deposition in the lung tissues, causing inflammation, coughing, shortness of breath, and potentially fibrosis over time.
And localized reactions to tetanus shots?
That can happen too, yes. especially if someone has received repeated tetanus immunizations over time and develops very high antibody levels. The next shot can lead to local immune complex formation and an Arthus-like reaction at the injection site, redness, swelling, pain.
Okay. Then there's serum sickness. That sounds systemic.
It is. Serum sickness is a systemic problem affecting the whole body. This is a widespread inflammatory reaction caused by the widespread deposition of immune complexes throughout the body's circulation and tissues. Historically, it was named because it followed the administration of large amounts of foreign serum, like horse antitoxins used to treat diphtheria or tetanus, before human-derived antibodies or specific antitoxins were available. The foreign proteins in the animal serum would act as antigens, forming massive immune complexes as the person developed antibodies.
We don't use horse serum much anymore, do we? Can it still happen?
It's less common now due to improved biologics and humanized antibodies. However, serum sickness can still occur with certain drugs, particularly large molecule medications like monoclonal antibodies, or sometimes even with common antibiotics like penicillin if complexes form.
And the symptoms are widespread.
Very much so. The clinical features are broad and systemic: fever, generalized aches, enlarged lymph nodes, lymphadenopathy, various rashes, often urticarial-like hives, or purpuric, which look like bruises, severe arthritis with joint pain, an enlarged spleen, splenomegaly, inflammation of the kidney filtering units, glomerulonephritis, and inflammation of blood vessels, vasculitis. It's truly a full-body inflammatory response driven by these complexes.
Another critical example you mentioned is post-streptococcal glomerulonephritis. This follows a strep infection.
Yes. Here, immune complexes formed after a streptococcal infection, like strep throat or a skin infection, impetigo, don't just stay localized. They circulate and deposit specifically in the glomeruli, the crucial filtering units of the kidneys. This deposition causes severe inflammation and damage to these delicate filters, ultimately leading to kidney dysfunction. You might see blood in the urine, swelling, edema, and high blood pressure.
So again, the immune response, not the bacteria directly, causes the kidney problem.
Correct. And immune complexes also play a significant role in the pathogenesis of other infectious diseases like infectious mononucleosis, hepatitis B, malaria, and secondary syphilis, where the complexes contribute significantly to the symptoms and pathology rather than just the pathogen itself.
What about the Schwarzman reaction mentioned in the source? Is that type 3?
The Schwarzman reaction. It's mentioned because it superficially resembles type 3 due to its localized hemorrhagic necrotic lesions, or in its generalized form, widespread coagulation. However, it's not strictly an immune reaction mediated by antigen-antibody complexes. It's often seen in severe gram-negative septicemia and is triggered by bacterial endotoxins, LPS. It typically requires 2 doses of endotoxin, a preparatory dose, followed by a provoking dose, and involves a rapid, overwhelming inflammatory response and clotting activation rather than immune complex deposition. So, similar outcome, different mechanism.
Interesting distinction. Okay, we've covered the immediate reactions types 1, 2, 3, and the variant type V, those lightning-fast antibody-driven responses unfolding in minutes to hours. But sometimes the body takes a slower, more deliberate approach to perceived threats, one that plays out not in minutes or hours, but over days. This brings us to a fundamentally different type of hypersensitivity, type 4 hypersensitivity, often called the cell-mediated delay.
Exactly. And it's a whole new ballgame because, crucially, as you said, there's absolutely no role for antibodies in this reaction.
No antibodies at all.
None. This reaction is instead mediated directly by specifically sensitized T lymphocytes and macrophages. That's why it's universally referred to as delayed type hypersensitivity, or DTH. The time lag is significant, requiring active cellular recruitment and cytokine production, which differentiates it completely from the immediate antibody-driven reactions.
So how does this cellular drama unfold without antibodies? Let's trace the mechanism. It still starts with sensitization, right?
Yes, the 2-stage process still applies. During that initial exposure, the sensitization phase, antigens are processed by specialized cells known as antigen-presenting cells, APCs.
Like macrophages or Langerhans cells in the skin.
Correct. These APCs are like the immune system's scouts. They capture the antigen, process it, and then present fragments of it on their cell surface in a specific way, usually using MHC molecules.
Okay. Who are they presented to?
These antigen fragments are then presented to a specific type of T lymphocyte, T helper 1, Th1 cells. This presentation activates the Th1 cells, causing them to proliferate and become sensitized, essentially getting them ready for action and forming a memory population.
So they're primed. Then what happens on re-exposure? the effector phase.
Right. Upon subsequent re-exposure to the same antigen, this is the effector phase, those previously activated memory Th1 cells recognize the antigen presented by APCs again. This time they unleash a barrage of powerful chemical messengers called cytokines.
Different cytokines than in type I.
Yes, different profile. Key cytokines here include IL-2, interferon gamma, IFN-NAC, and macrophage activation factor, MAF, among others. These act as potent signals. They recruit and activate a host of other immune cells, particularly macrophages and other non-specific inflammatory cells to the site of antigen re-exposure.
And the activated macrophages cause damage.
Yes. Once activated by cytokines like IFN-NA, these macrophages become highly aggressive. They enlarge, increase their phagocytic activity, and release lytic enzymes and reactive oxygen species, which unfortunately cause significant local tissue damage as they try to eliminate the antigen. Additionally, in some type 5 reactions, cytotoxic TC cells, CD8+, can also participate directly. These cells recognize antigen presented on MHC class I molecules on target cells, like virus-infected cells or graft cells, and kill them directly. It's a direct cell-on-cell attack.
That delayed onset is truly a key differentiator, isn't it? You get exposed to something, maybe poison ivy, and then you have to wait 24 to 72 hours, sometimes even longer, for that characteristic rash or inflammatory reaction to show up.
Exactly. It's not an immediate explosion, but a slow burn, reflecting the time it takes for T-cell activation, cytokine release, and macrophage recruitment and activation.
And another really important characteristic of type 5e reactions, underscoring that antibodies are not involved, is what you called cellular transfer.
Yes, this was a critical experimental finding. Unlike antibody-mediated reactions, types 1, 2, 3, this type of hypersensitivity can actually be passively transferred from a sensitized individual to a non-sensitized one by transferring lymphocytes or even a cell extract called transfer factor. But, crucially, it cannot be transferred by serum because serum is where the antibodies are found. This experimental observation was fundamental in proving that cells, specifically T lymphocytes, not antibodies, were the primary mediators of DTH.
That's solid proof. Now, for some classic examples that you might be familiar with, the most textbook example is tuberculin-type hypersensitivity, right? The TB skin test.
Yes, often referred to as the infection type. This is famously demonstrated by the tuberculin skin test, like the MAN2 test, which is widely used for screening for tuberculosis exposure or infection.
How does that work again?
In this test, a purified protein derivative, PPD, from Mycobacterium tuberculosis is injected intradermally just under the skin. A positive reaction isn't immediate, as we noted. Instead, it's characterized by induration, a palpable hardening and thickening of the skin, and erythema, redness, that develops after 48 to 72 hours. That positive result indicates prior exposure to or infection with the bacterium, meaning your Th1 cells have been sensitized and mount this recall response. It's a memory response of the cellular immune system.
And within this context, we have Coase phenomena. What was that?
Yes, described by Robert Koch himself. This describes the exaggerated, accelerated inflammatory response seen when a guinea pig previously infected with tubercle bacilli is re-injected with the same bacteria. Instead of a slow, typical lesion developing over weeks, you get a rapid, intense inflammatory reaction with necrosis at the injection site within a day or two. It truly highlights the fascinating interplay of pre-existing hypersensitivity, the DTH response, and the protective immunity that can simultaneously exist within the host against the same organism.
Interesting. Okay. A very common one we've all likely encountered, directly or indirectly, is allergic contact dermatitis, poison ivy rash, nickel allergy.
Exactly. This is that intensely itchy eczematous rash with redness, swelling, and small blisters or vesicles that you get from things like poison ivy or poison oak, which contain a chemical called urushiol, or from nickel in jewelry, certain cosmetics, or specific drugs applied topically.
And these happens again.
Yes, these substances are typically happen small molecules that, by themselves, are non-immunogenic. But when they penetrate the skin, they combine with our own skin proteins to form a complete immunogenic antigen.
So the body reacts to its own protein, but only when the hapten is attached.
Precisely. Upon re-exposure, your sensitized T cells recognize this modified protein presented by skin APCs like Langerhans cells, leading to that characteristic delayed rash. It's a prime example of why sometimes something seemingly innocuous can trigger a profound immune response once it's presented differently.
And because it's a delayed reaction, it's typically diagnosed with a patch test, right, where they tape allergens to your back.
Exactly. Suspected allergens are taped to the skin for a couple of days to see if a localized type 5V reaction develops at the site.
And in the realm of modern medicine, graft rejection is a critical and life-altering example of type IV hypersensitivity, isn't it?
Absolutely. In transplantation medicine, the recipient's immune system, particularly its cell-mediated responses, both Th1 and cytotoxic T cells, to allantogens, the MHC molecules on the transplanted tissue that are recognized as foreign, mount a vigorous attack. The T cells of the recipient recognize the graft as non-self and initiate an inflammatory cascade aimed at destroying it.
It's the body doing its job of identifying and eliminating foreign material, but in a situation where we desperately wanted to accept the foreign material. A huge challenge.
A major challenge, yes. Other examples where type IV mechanisms are important include tumor immunity, where the immune system, especially cytotoxic T cells, plays a crucial role in recognizing and eliminating tumor cells, acting as a surveillance mechanism.
And some autoimmune diseases.
Yes, some autoimmune diseases, like Hashimoto's thyroiditis, involve significant cell-mediated immune mechanisms leading to tissue destruction. In Hashimoto's, T cells infiltrate and destroy the thyroid gland, resulting in hypothyroidism.
And finally, a chronic and often destructive form of type IV hypersensitivity is granulomatous hypersensitivity. What's that?
This occurs when persistent stimulation of macrophages and T cells by difficult-to-eradicate antigens, often intracellular pathogens like the bacteria causing tuberculosis or leprosy, or certain fungi, leads to the formation of granulomas.
Granulomas, walls of cells.
Pretty much. They are distinct, organized collections of immune cells, primarily activated macrophages, which can fuse to form giant cells, surrounded by lymphocytes. You see this in chronic infectious diseases like leprosy, tuberculosis, and leishmaniasis. The body walls off the persistent irritant, but the granuloma itself can cause significant tissue destruction and organ dysfunction due to the chronic inflammation in space it occupies. It's a prolonged, localized, and often destructive immune response.
Okay, that covers the specific types of hypersensitivity reactions, from the immediate IgE-driven allergies to the delayed cell-mediated responses. It's quite a spectrum.
It really is.
But now, let's zoom out and look at some broader perspectives, starting with something critically important: immunopathogenesis. Can you explain that concept?
Certainly. Immunopathogenesis is the big idea that in many diseases, the symptoms, the tissue damage, and the overall pathology are not directly caused by the invading microorganism or its toxins. Instead, they're caused by the host's own exaggerated or inappropriate immune response to that pathogen.
So the immune response is the disease, or at least a major part of it.
Often, yes. It's the ultimate paradox. The body's attempt to defend itself actually becomes the primary source of harm. This concept completely transforms our understanding of disease. It asks, how often does our defense become our downfall?
We've already seen some examples, haven't we? Like rheumatic fever.
Exactly. Rheumatic fever is a powerful example. Antibodies produced against Streptococcus pyogenes cross-react with our own heart, joint, and brain tissues, causing the debilitating symptoms and long-term heart valve damage. The strep itself doesn't directly damage the heart. The immune response to it does.
And post-streptococcal glomerulonephritis.
Same story, different target. The severe kidney damage happens because immune complexes formed after a strep infection deposit in the kidney glomeruli, not because of a direct bacterial attack on the kidney itself. It's the aftermath, the immune system's cleanup attempting to deal with those complexes, that causes the profound trouble, potentially leading to chronic kidney disease.
What about other diseases? Syphilis.
Similarly, the characteristic pathogenic lesions of syphilis, especially in its later stages, tertiary syphilis, are primarily caused by the host's chronic immune response, often granulomatous, to the bacterium Treponema pallidum. It's not the bacteria directly destroying the tissue in most cases. It's the intense inflammatory reaction mounted by the body against the persistent presence of the spirochete.
Okay, here's where it gets really interesting and a bit counterintuitive, according to the notes. Dengue hemorrhagic fever. How does the immune system cause problems there?
Dengue is fascinating and dangerous. The severe, life-threatening manifestations, hemorrhagic fever and shock syndrome, are widely believed to be due to a hyperimmune response, often involving a phenomenon called antibody-dependent enhancement, ADE.
Antibody-dependent enhancement. Antibodies making it worse? How?
Normally, antibodies protect you, but dengue virus has multiple serotypes. If someone gets infected with a different serotype of dengue virus after having been previously infected and recovered from another serotype, the pre-existing non-neutralizing dengue antibodies from the first infection can actually bind to the new virus.
Okay.
But instead of neutralizing it, they enhance the entry of the new virus into mononuclear cells, like macrophages, via Fc receptors.
So the antibodies act like a Trojan horse, helping the virus get inside the very cells meant to fight it.
That's a good way to put it. This enhanced entry leads to a much higher viral load and an overwhelming cytokine storm, a massive uncontrolled outpouring of cytokines from the activated immune cells. This cytokine storm then triggers widespread blood clotting issues, disseminated intravascular coagulation or DIC, leaky blood vessels leading to plasma leakage and shock, and organ failure. It's a terrifying scenario where the very antibodies that should offer protection ironically contribute to the severity of the disease.
Wow, the immune system's accelerator gets stuck wide open.
Precisely, pushing the body to its limits and beyond.
And even common childhood viral diseases like measles and mumps. Immunopathogenesis plays a role there too.
Yes, their classic clinical manifestations like the characteristic rashes and swelling like parotitis and mumps are largely due to the cell-mediated immune response, type 4, to the virus infecting various tissues, rather than direct viral damage killing the cells themselves. It's the immune system responding to the infection that gives rise to the classic symptoms, proving just how much of our sickness experience is our own body's reaction.
That's really something to think about. And leprosy.
Leprosy is another prime example. The progression and vastly different clinical forms of leprosy, from tuberculoid to lepromatous, are highly dependent on the strength and type of the host's cell-mediated immune response to Mycobacterium leprae. Paradoxically, a strong but sometimes dysregulated T-cell immunity can even trigger severe inflammatory episodes known as leper reactions, type I and type 2. These are acute hypersensitivity events superimposed on the chronic infection, and they can cause sudden and severe nerve damage and disfigurement, often requiring urgent treatment with immunosuppressants. It's a constant tightrope walk between effective immunity and immunopathology.
This raises a truly important question. Why do some individuals react with these exaggerated hypersensitivity responses while others don't, even when exposed to the same exact antigen? This brings us to the crucial factors influencing hypersensitivity.
Absolutely. It's never just one thing. It's a complex interplay of both host factors, what's unique about the individual, and antigen factors, what's unique about the trigger itself.
Let's start with host factors. Genetics must play a huge role, right?
A massive role. Your genetic constitution is a major determinant. It significantly predisposes people to allergies, as we discussed with atopy for type I reactions, that tendency to make IgE. It also predisposes people to a wide array of autoimmune diseases. For instance, specific variations in certain HLA, human leukocyte antigen genes, which are critical for how antigens are presented to T cells, are strongly linked to an increased risk of developing particular autoimmune conditions like type 1 diabetes, rheumatoid arthritis, or multiple sclerosis. Your genetic blueprint really dictates how your immune system sees and reacts to the world.
What about your overall immune status?
That matters tremendously too. Immunocompromised individuals may be due to illness like HIV or medications like chemotherapy or transplant anti-rejection drugs might not only experience more severe or disseminated infections, they might also exhibit altered or dysregulated hypersensitivity responses as their weakened immune system struggles to mount an appropriate balanced defense. Sometimes the lack of regulation is the problem.
In age, does that affect reactions?
Yes, definitely. The immune system changes throughout life. Extremes of age infants whose immune systems are still developing and calibrating, and the elderly whose immune systems are often declining in efficiency, immunosenescence, can affect susceptibility to infections and profoundly influence the nature of their immune responses. They might be more prone to certain hypersensitivities or experience more severe forms of reactions.
What about hormonal levels? Do hormones influence immunity?
They absolutely do. Hormonal disorders such as diabetes mellitus, hypothyroidism, or even the significant hormonal shifts during pregnancy can influence susceptibility to infections and alter the immune response. Sometimes sensitivities can worsen or even appear during pregnancy, for example. It's a clear reminder that the immune system doesn't operate in a vacuum. It's interconnected with the endocrine system.
And just basic nutritional status.
Critically important. Malnutrition, particularly deficiencies in key vitamins and minerals like vitamin D, zinc, vitamin A, can significantly weaken both humoral, antibody-mediated, and cell-mediated immunity. This broad weakening can make you more vulnerable to infections, but also potentially alter the delicate balance required for appropriate immune responses, possibly predisposing to dysregulation and hypersensitivity. Good nutrition supports a well-functioning immune system.
Okay, so that's the host side, all the individual variables, but the trigger itself, the antigen factors, also really matter, don't they?
Absolutely. The characteristics of the antigen itself are key, things like its molecular size and complexity. Generally, larger and more complex molecules, especially proteins, are more likely to be recognized as foreign and induce a strong, often potent immune response. The immune system is more likely to react vigorously to a large, intricate structure than a tiny, simple one.
And how foreign it looks. Foreignness.
Precisely. The more foreign a substance is perceived by the immune system, the more different it is from the body's own molecules, the stronger the immune response generated against it. This makes intuitive sense. The body is designed to target what it doesn't recognize as self. A completely novel protein from a bacteria will likely elicit a far stronger response than a slightly altered self-protein.
Now, this is really interesting, the dosage and route of administration. How does that influence things?
This is fascinating because it's not always straightforward. You might think more antigen equals bigger reaction, but that's not always true. Both very low doses and extremely high doses of an antigen can sometimes induce tolerance, a state of non-responsiveness or active suppression of the immune response, rather than an active immune reaction.
Tolerance. So too little or too much can shut the response down.
In some circumstances, yes. It's a remarkable regulatory mechanism, likely evolved to prevent unnecessary reactions to trace environmental substances or overwhelming self-antigens. It's the moderate, often repeated doses that are typically most immunogenic, meaning they are most likely to provoke a strong immune response and sensitization.
And the route matters too, how it gets in.
Profoundly. The route of administration, whether it's oral, ingested, nasal inhaled, parenteral, like injection, or through the skin, can significantly influence the specific type of immune response generated and the class of antibody produced. For example, exposure via mucosal surfaces, like the gut or respiratory tract, often favors IgA production, which provides local protection at those surfaces. Systemic injections, on the other hand, might predominantly elicit IgG responses circulating in the blood. This difference helps explain why eating a peanut might cause gut symptoms or anaphylaxis type I, while skin contact might cause contact dermatitis type I in a sensitized person.
Okay. And finally, a particularly dangerous and fascinating class of molecules mentioned, superantigens. What makes them so super?
Superantigens are special and highly potent toxins, primarily produced by certain bacteria, like Staphylococcus aureus, causing toxic shock syndrome, food poisoning, or Streptococcus pyogenes, causing toxic shock-like syndrome, starlet fever. What makes them so unique and dangerous is that they don't require conventional antigen processing and presentation by APCs, the way normal antigens do. They cheat the system.
How do they cheat?
Instead of fitting neatly into the antigen-binding groove of the MHC molecule to be presented specifically to a T cell with the right receptor, superantigens bypass that specific recognition system entirely. They act like a molecular clamp or glue, non-specifically binding directly to the outside of both the T cell receptor on many different T cells and the MHC class II molecule on antigen-presenting cells.
So they link lots of cells together randomly.
Exactly. This forces a massive number of T cells, often up to 20-30% of the body's total T cell repertoire, and antigen-presenting cells become activated all at once, regardless of their actual antigen specificity.
That sounds like chaos.
It is immunological chaos. It's like the immune system's accelerator gets stuck wide open, bypassing all the normal checks and balances. This leads to an overwhelming and uncontrolled cytokine storm, a huge systemic outpouring of pro-inflammatory cytokines from all those non-specifically activated cells. This massive cytokine release can cause life-threatening symptoms: high fever, low blood pressure, rash, multi-organ failure, essentially autoimmune-like responses, and multi-system dysfunction. This is the mechanism behind severe conditions like toxic shock syndrome. It's a truly frightening example of the immune system's protective power being turned against the host in a devastating, non-specific way.
Wow. Superantigens sound incredibly dangerous.
Yeah.
So we've taken a really comprehensive deep dive today into hypersensitivity reactions, exploring the intricate and sometimes, well, dangerous dance of the immune system. We've seen how this incredible system, designed to protect us, can inadvertently turn its immense power inward, causing pathology rather than protection. It's become abundantly clear that while our body's defenses are absolutely essential for our survival, they operate on a real razor's edge, where protection can inadvertently become pathology.
It's fascinating, isn't it? And what's crucial to remember is that hypersensitivity reactions are far more than just allergies in the common understanding. They represent a complex spectrum of immune-mediated responses, each with its unique mechanism: IgE, cytotoxic antibodies, immune complexes, T cells, and its unique clinical manifestation. But the common thread is that in all these reactions, the very mechanisms designed to protect us end up causing harm to our own tissues. It's a powerful illustration of the delicate and precise balance required for a functional immune system, and the severe consequences when that balance is lost or misdirected.
Absolutely.
Yeah.
And as we wrap up, it leaves us with a truly thought-provoking question, I think, one that extends beyond the immediate clinical impact. Considering the incredible sophistication and evolutionary refinement of our immune system, all the checks and balances, and the sheer number of foreign substances it encounters nonstop throughout our entire lives, what does the very existence of these overreactions, these hypersensitivities, tell us about the evolutionary trade-offs involved in building such a powerful and versatile defense mechanism?
That's a great question. Is a perfectly balanced immune system even possible? One that never makes a mistake, never overreacts.
Right. Or are these hypersensitivities, these allergies and autoimmune issues, maybe an unavoidable consequence, a necessary, albeit unfortunate, side effect of having a defense system potent enough and adaptable enough to keep truly dangerous pathogens, bacteria, viruses, parasites at bay most of the time?
It really makes you think about the cost of protection, doesn't it? An inherent flaw. Or just the price we pay for surviving in a hostile world.
Something to definitely ponder long after this deep dive.